Hello friends, in the series of AIIMS question discussion, today is the third session. First of all, I am sorry, today our routine studio where we do all the recordings, it's occupied. So now I am recording in a very ordinary place with an ordinary camera. Okay? So, AIIMS question discussion number 3. Right? Let us see the first question. A patient presented with history of vomiting for last 3 days. On examination, signs of dehydration were present. On further investigation, the patient was found to have raised creatinine, pH of 7.22, PaCO2 of 21 mm, bicarbonate of 9 milliequivalent, sodium of 138 milliequivalent, potassium of 3.4. What identify the acid-base abnormality observed in this patient? The options are A. Metabolic acidosis, B. Metabolic alkalosis, C. Mixed metabolic acidosis and respiratory alkalosis, 4. Mixed respiratory acidosis and metabolic alkalosis. The answer of this question is C, that is mixed metabolic acidosis and respiratory alkalosis. Now, why the answer is C? Because nowadays you always get one question on acid-base disturbance. So I'd like to discuss more about acid-base disturbance. So normal pH of the body is 7.36 to 7.44. Okay, 7.44. For average, I take as 7.40. And normal bicarbonate is 22 to 28 milliequivalent. For average, I am taking as 24. And normal bicarbonate, PaCO2 is 40 to 45. This is the arterial and this is the venous, because all samples are taken from artery. So PaCO2 we always take as 40. Okay. Now let us see how does acidosis and alkalosis occur in the body. But before that, there is confusion to around 20% student. In our school days, we were taught the normal pH is 7. Anything above 7 is alkali. Anything below 7 is acid. As per school teaching of physics and chemistry, pH of 7.21 is alkali. But in the medical science, normal pH is 7.40. Anything above 7.40 is alkali, anything below this is acid. As per our medical teaching, 7.21 is acid. But as per school physics and chemistry, 7.21 is alkali. This point should be clear to all of you. Now, we move further. We should learn the basic concept more. The more basic concept, this is the acid controlled by lungs, and this is alkali controlled by the kidneys. These are too basic to talk at your level. Now let us see, how does acidosis and alkalosis occur in the body? This is acid, this is alkali. Gain of acid is acidosis. Loss of alkali is acidosis. Gain of alkali is alkalosis. Loss of acid is alkalosis. It means acidosis can occur due to gain acid or loss alkali. Similarly, alkalosis can occur due to gain alkali or loss acid. Got it? I hope you are clear about this basic fundamental. We have more. So let's talk more basic concept. We continue with basic concept. Now, the basic concept, any disturbance of CO2 is respiratory. any disturbance of bicarbonate is metabolic. These are the basic concepts. Now, based on this basic concept, suppose I get one patient whose CO2 is increased. So we have just learned any disturbance of CO2 is respiratory and CO2 is acid. Gain of acid is respiratory acidosis. So it should be a case of respiratory acidosis. Suppose we get one patient whose CO2 is reduced. Any disturbance of CO2 is respiratory and CO2 is an acid. Lowering of acid lead to alkalosis. So it should be respiratory alkalosis. Suppose I get one patient whose bicarbonate is increased. Any disturbance of bicarb is known as metabolic. Okay. And gain of bicarb is a alkali. So gain of alkali should be metabolic alkalosis. And suppose I get one patient whose bicarbonate is reduced, metabolic acidosis. This is the key thing that you got to remember, right? Now, what happens? This is the basic, I hope now your things are very, very clear to you. Now, whenever there is disturbance of any pH, remember, I told you this is a normal pH, but life can sustain from 7.7 to 7.0. If beyond this, body cannot survive. And body has made some mechanism by which pH is brought back to normal. This is known as compensation. Now what happens? Suppose there is metabolic acidosis there. Patient has small breathing. Small breathing because a lot of acid is there. Body want to lose acid, so there is tachypnea. Small breathing is there. So CO2 level goes down. As per compensation, CO2 level goes down. And low CO2, that means the compensation by respiratory alkalosis. Similarly, in case of metabolic alkalosis, body will try to retain CO2. So body will try to compensate by retained CO2. That means body will try to produce respiratory acidosis in the body. Similarly, suppose this patient has got respiratory acidosis, body will try to retain more and more bicarbonate. So increased bicarbonate will be the compensation. In respiratory alkalosis, there should be low bicarbonate, so-called compensation. This is compensation. Compensation. Got it? So now if you come back to our question, okay, so in this the pH is 7.22, there is acidosis is there, bicarbonate is low, it's a metabolic acidosis, CO2 is also low, that means body has tried to compensate by respiratory alkalosis. Hence the best answer of this question is C, mixed metabolic acidosis and respiratory alkalosis. Okay? Now we talk about question number 2. Continuous murmur can be heard in all except option A, VSD with aortic regurgitation, B, coronary AV fistula, C, pulmonary AV fistula, D, patent ductus arteriosus. The answer of this question is A, VSD with aortic regurgitation. Well, in AV fistula, whether coronary or pulmonary and PDA, you get continuous murmur. In fact, especially in case of PDA, you get the murmur what we call as machinery murmur. But in VSD, you get Pansystolic murmur. And in AR, this is what happened in VSD. In AR, this is early diastolic murmur. So it is not a continuous murmur. Now, what are the other causes of pansystolic murmur? It is pansystolic murmur is seen not only in VSD, it also seen in mitral regurgitation and tricuspid regurgitation. What are the other causes of early diastolic murmur other than the AR? Is also seen in pulmonary regurgitation. Okay, and the murmur of pulmonary regurgitation is also known as Graham-Steele murmur. So hence the answer of question number 2 is A is the answer. Now let us see question number 3. Which of the following is not true about salivary gland output in Sjogren's syndrome? A. Increase in sodium concentration. B. Increase in phosphate concentration. C. Decrease output of salivary gland less than 0.5 ml per minute. D. Increase in IgA concentration. The answer of this question is C. Decrease output of salivary gland less than 0.5. Now, why this the answer? Why not others? So first of all, we know something about Sjogren's syndrome. Sjogren's syndrome is an autoimmune disorder characterized by bilateral parotid enlargement. There is dry eyes, dry mouth. Okay. This is the classical triad. Most of the time it may be primary or it may be secondary. Primary means it is idiopathic. But secondary, there is some associated other any autoimmune disease, like rheumatoid arthritis, which is the most common cause. It can occur in SLE, it can occur in scleroderma, primary biliary cirrhosis, so many other conditions it can be there. And usually the primary one is HLA-DR3 and secondary is usually HLA-DR4. Now in these cases, in the saliva, the concentration of sodium increases, concentration of phosphate increases, and even IgA level of increase in saliva. But as far as salivary gland outflow, this is less than 0.1.5. But in the option given is 0.5. So it is not 0.5, it is 1.5. Hence the best answer of question number 3 is C. Decrease output of salivary gland by less than 0.5 ml per minute. Let's talk about question number 4. A patient is diagnosed with carcinoma of lung presented with serum calcium level of 16.4 milligram per cell. What should be the first line treatment in the management? IV fluid and furosemide, immediate hemodialysis, biphosphonate or subcutaneous calcitonin. The answer of this question is A. IV fluid with furosemide. This is question number 4. First of all, what the problem? Problem here is of hypercalcemia. And it is 16.4. It is very, very high. And it is a case of lung cancer. The first question, very, very important. Which lung cancer causes hypercalcemia? It is squamous cell. This is a very, very important question. Why? Because we know lung cancer have many endocrine features. All of them are due to small cell, except hypercalcemia, which occur due to squamous cell. Now, hypercalcemia is of this category of 16.4 is a medical emergency. Patient should be hospitalized in the ICU, and immediately patient should be given lot of IV saline. Why? Because of hypercalcemia, patient develop nephrogenic diabetes insipidus. That means tubules are resistant to action of ADH. The patient has lot of polyuria, polydipsia, and they are totally dehydrated. So first we have to give saline. After that we give furosemide. Why furosemide? Because this causes loss of calcium in the urine. Just remember, thiazide causes calcium retention. That's the cause of hypercalcemia. It is a treatment of hypercalcemia. What about other option is immediate hemodialysis. Hemodialysis is never the first line treatment. It is a treatment but not the first line treatment. Biphosphonate is used for chronic hypercalcemia, not for acute hypercalcemia. And subcutaneous calcitonin. First of all, calcitonin is never given as subcutaneous. It is always given as nasal spray. And calcitonin is a short-acting drug. It is used only in a chronic cases. We start biphosphonate. Until the action of biphosphonate start, we keep on giving calcitonin. And once the action of biphosphonate start in about 7 to 10 days, then we can withdraw the calcitonin. Hence, the answer of the question number 4 is A is the best answer. Let's look into question number 5. Pelvizumab is used for prophylaxis of metapneumovirus, parainfluenza, influenza, or RSV. It is a straightforward question. The answer is RSV, respiratory syncytial virus. It's just a there's nothing to discuss about it. Okay, RSV. Let's look into question number 6. A lady is brought to emergency room in an unconscious state. She has previous history of such attack in the past month. ECG done. The graph obtained show which the following is the most likely cause. PSVT, atrial flutter, ventricular bigeminy, and 2:1 block. The answer is 2:1 block. Why? Look at this thing. What we are getting here is P wave, P wave. Okay, P wave and P wave. Right? So after 2 we are getting typical this thing. P wave, Q ka, this thing. So answer this is 2:1 block. 2P, 1 QRS. What about PSVT? In PSVT, we got a lot of the atrial discharge rate is in the rate of about 150 to 220. It's not there. Atrial flutter, we classically get sawtooth appearance. It is not there. What about ventricle bigeminy? Ventricle bigeminy is normal wave, then ectopic, normal, ectopic, ectopic. Normal wave, ectopic. This is not the finding. So the best option of, although it's not a classical recording of 2:1 block, but still we can say this is the much better option out of all other options given in the question. Question number 7. A 34-year-old male is presented with the complaint of dyspnea and productive cough with postal variation. The patient gave history of 20 pack years of smoking. Patient also have a history of recent binge drinking. A chest X-ray was taken is shown below. What is the next step in the management? In the chest X-ray, if you look at, if you can appreciate, there is some abscess is there. Here is the abscess. So, gemcitabine and carboplatin-based chemotherapy, lobectomy, intravenous clindamycin and fluid, anti-tubercular therapy. Well, large amount of dyspnea, pruritica with postal variation. This is what we see in case of lung abscess. Okay. And this is usually due to aspiration, and aspiration contain oral microbials which are usually anaerobic. So in the lung abscess, what we have in this patient, the one antibiotic which is effective against this is clindamycin. Okay, so clindamycin is the best answer in this case to look for the. So initial therapy is always antibiotic, clindamycin. But if patient does not respond, then we can think of internal or external drainage. Okay. Lobectomy is not the answer, first line treatment, and same thing, antitubercular treatment is not an option in this case. Question number 8. If patient has worm infection with the no systemic complaint, what should be absolute eosinophil count to call it is hypereosinophilic syndrome? More than 500, 1500, 1000 or 2000? It is again a straightforward question, or answer is more than 1500. It's a factual question. When the absolute eosinophil count is more than 1500 per ml, this is called hypereosinophilic syndrome. Well, worms are very common cause in our country. Okay, but otherwise, one more thing, when the patient has worm infestation, usually worms are not there in circulation. And how to get the worms? You do hetrazan tests. Okay, normally in a routine case, worms come out between 10 p.m. to 2 a.m. But otherwise, if you want to see in the morning hours, you have to give hetrazan, and after half an hour and within 1 hour, this time worms come out in the circulation. Then you take a peripheral smear, then you can see. Now, extra edge, one more very important condition where hypereosinophilia occurs is myeloproliferative disorder. Okay. Now, next question. Calculate the base deficit in a patient weighing 75 kg with a pH 6.96, CO2 30, and bicarbonate 6. The answer 300, 400, 500, and 800. The answer is 400. So before that, let us see how we really calculate the base deficit. Base deficit is calculated as follows. It is 0.3 multiplied by body weight in kg divided by what is expected bicarbonate minus observed bicarbonate. So as per this 0.3, weight is 75, expected bicarb is 24, I just discussed, normal CO2 is 24, and in this case is 6. If you calculate, this comes out to be 405. Okay, so the best answer to this question is 400 is the best answer. Well, question number 10. Signs of respiratory insufficiency are all except hoarseness of voice, inability to speak, high-pitched sound, and decreased breath sound. Answer is hoarseness of voice. Well, this is typically what we have in severe asthma. The other feature, others, so patient cannot speak a single sentence in one breath. Patient has tachypnea. Patient has tachycardia. Patient has pulses, paradoxes, and FEV1 is less than 50%. But in terminally ill patient of severe asthma, patient develops cyanosis, altered sensorium, silent chest, there is no air entry at all because of severe bronchospasm, and wheeze is in fact is a feature of asthma as such, and in severe cases FEV1 is less than 30%. Hoarseness of voice is not a parameter of severity of a case of bronchial asthma. Okay, now before I close today's session, friends, you can see I have recorded lot of lectures on various topics of medicine. You can see our YouTube channel, that is Dr. Bhatia Medical Coaching Institute, DBMCI. And one more thing, I have a broadcast group where I send all my students lot of motivated points and last minute revision point. You can send your name, you are in which year, which college, city of your college, email to my personal WhatsApp number given to you. I'll be sending you lots of updates. Okay, lot of updates. And I'll be trying to do as much as discussion after AIIMS. I like to discuss PGI questions also and JIPMER questions also. Thank you very much for watching this video, and again I'm sorry I could not do recording in a proper studio, but still I have to do the test discussion, so I thought better to recording maybe in a ordinary studio, but work should be done. That is more important. Thank you very much for watching this video.